A very good evening, everyone. I'm Dr. M. Shriya Jaiswal, currently pursuing PhD in oral and maxillofacial surgery from Busan National University, South Korea, and I'm the host for today's session. Today, we have Dr. Tejashvi Seth from India with us. She has completed her BDS from Terna Dental College and MDS in Periodontology and Oral Implantology from MGB Dental College, India. She is a dedicated educator, actively involved in periodontology workshops and implant restoration training for dental professionals. Her clinical expertise include periodontal surgery, implants, regenerative procedures, etc. She is also the member of Indian Society of Periodontology. Moreover, she has 7 publications in international indexed journal, and currently she is working as a periodontist in Percy James Dental World, Mumbai. So now, without any delay, let's talk about the topic of today's session, which is principles of flap design around dental implants. So basically, the success of dental implant placement relies not only on precise implant positioning, but also on careful soft tissue management. So one of the key aspects of this process is flap design, which plays a crucial role in ensuring adequate surgical access, preserving blood supply, and promoting optimal healing. Flap design around dental implants must be carefully planned to minimize trauma, reduce post-operative complications, and facilitate aesthetic and function outcomes. Various factors, including incision type or flap thickness and tension-free closure, must be considered to enhance the soft tissue integration and long-term implant stability. So get ready to decode the secrets of the fundamental principles of flap design in implant dentistry. So before starting this session, let me tell a few points to all the attendees that if you have joined live and have any queries or any doubts, then you may put your questions in Q&A box in the control panel and it will be answered accordingly at the end of this session. So now all over to you, Dr. Tejashvi. Let's begin. You may start.
Hello, thank you, Shriya, for such lovely introduction. And thank you, Quickdent and Dentist Channel Online for having me here. So, I'll be sharing my screen now. Is that?
Yeah. Yeah.
So, coming to today's topic, which is flap design around dental implants. Now, with advent of implantology, like previously during the time of Brenmark, there was extensive duration required between your first stage and second stage surgery, the entire implant placement to your restoration. Usually, it used to be somewhere around 6 months for even if it is a single implant. But with advent in implantology, now we don't wait for such longer time, and there are a lot of stent and guides are also used. So, if such advent is already there, and if you could do your implant placement flapless, why do we require flap? That is supposed to be the very basic question, why we are still going back to the basic principles, something which you or most of us have somewhere read during our undergraduate time, that why we do require to revisit such basic principles again. So there is a lot of evidence if we come across that why, even though flapless, whenever you do some flapless surgery, all you require is just a tissue punch, and there's no extensive flap elevation or tissue trauma or anything. So the evidence have said that okay, the flapless surgery does provide less amount of crestal bone loss as compared to open flap implant placement, but the evidence is something which is even not consistent. The earlier studies have shown that there's hardly any significant difference between the crestal bone loss, and the more recent one shows okay, there is certain amount of difference, as in it is less traumatic and the crestal bone loss is less. So even though there is a confusing amount of data what you should go for. Uh, the basic prerequisite comes down to whether there is adequate amount of keratinized attached non-mobile tissue, which should
Uh,
be at least
Sorry
5.
to interrupt, Dr. Tejashvi. Have you shared your screen?
Yes, yes.
Oh, I can't see it.
One
Can you
second.
please check this? Yeah.
Is it visible?
Yeah, now it's visible. Okay.
Okay. So, the basically the prerequisite for any kind of flapless implant placement comes down to how much amount of keratinized tissue you have and how much amount of bone you have. If there is an adequate amount of bone, at least 4.5 mm, so that you can place a smaller diameter implant without any undercuts, and if you have approximately 5 mm of keratinized tissue, you could definitely go for flapless placement. But the scenario is not always you will find such amount of good tissue, such amount of good bone. So we do require to open a flap. So why does flap design matter? Why do we have to come to this very basic? Now, if you could see this slide, there's an implant, but what about the soft tissue? The placement might have been very nice, but you can see there's some kind of graft exposure is there. There's some amount of tissue tension is there. So even though you have a proper implant placement done, your flap is not good, your closure is not good. Ultimately, the peri-implant tissues also dictate how much successful your implants will be. Again, this slide, if you see, there's dehiscence. This is a single implant placement, but if there is a dehiscence, it will affect the longevity of your implant. And now if you come to this, which is a very aesthetic zone, your anterior aesthetic zone, there are a lot of things which is going wrong in this slide. Your incision lines or the tension pull from the frenum, the exposure of your membrane. So no matter how good your placement will be, it will ultimately have some kind of dependence on how you manipulate your soft tissues as well. So let's come down to very basic. What kind of flap reflection you require? A full thickness or a partial thickness? The gingival reflection that we do, that ultimately depends upon what kind of biotype you have, whether you have a thin biotype or thick biotype. And a very basic way to judge is just put a probe, and if you can see the shadow of the probe, that means you have a very thin biotype. And if the probe is not visible, then you have a thick biotype. So see, even though there's some amount of tissue hypoxia when you reflect a full thickness flap. Basically, a full thickness flap is when your periosteum, connective tissue, and epithelium is entirely reflected from the bone. And a partial thickness is where there is some type of connective tissue is still attached to the bone. So if you compare your full thickness with the partial thickness, the tissue hypoxia will be comparatively lesser in partial thickness. But if you don't have that thick biotype, you might not be able to do a partial thickness. You will ultimately have to reflect a full thickness. If you just go on reflecting a partial thickness in a thin biotype, ultimately there will be some amount of flap necrosis, because the connective tissue which is required to give the ample amount of blood supply, that will be hampered. So your flap ultimately will be necrosed. So now when you, a basic technique, when you reflect a full thickness flap, and if you have planned for a full thickness flap based on biotype requirement or whether you require any sort of grafting or not, the thing you have to consider is give a very minimal, very less traumatic reflection. Just scrape through the bone so that your periosteum does not tear. There is no amount of tissue edema. So the patient discomfort is also comparatively lesser as compared to when you're just giving a very traumatic flap reflection. And if you see here, there's some amount of tissue present. So your flap reflection might not be just a complete full thickness or a complete partial thickness. It can go from full, partial, full, or any which way based on how much your biotype is, whether it is thick or whether it is thin. Now coming to the basic flap techniques in dental implantology, let us consider the first one, which is the envelope flap. Envelope flap, basically all you have to do is give a intracircular incision, then give a mid-crestal incision, then again the adjacent tooth has to be a intracircular incision. This is your first incision line, this is the second, and this is your third in a continuous movement. Now, if you just see your mid-crestal in this slide is not exactly mid-crestal. The incision line is little bit on your far away from the buccal side. And that is very simple because if you can see, there is a depression in this area. So we want to push the tissue outwards. So anytime you give a mid-crestal, you have to ask yourself whether you want to push the tissue a bit buccal or how is the ridge over there? How is the tissue adaptation over there? And if you're planning for any augmentative procedures along with your implant placement. This is a full thickness flap reflection. And here you can see there's no amount of periosteum present. We cannot see any kind of defect. So it might not require any augmentative procedure. Well and good. Then place your implants directly, close, have a tension-free closure and suture it. And whenever you are reflecting the flap, avoid any kind of uh, trauma or very much pull. Now, if you can see, there is some amount of tissue tension here and here. Again, because the intracircular incision that we have given is not uh, circumventing the entire tooth. So this becomes somewhat a disadvantage when you want to plan any grafting, because at that time you don't require such kind of tensions. If you want grafting, you have to just release it more, put your bone graft, and then suture it. Again, any kind of graft material that you will put, it will require proper space and a tension-free closure. So there is this mattress suture along with your interrupted suture. The advantages, it is very easy to suture whenever you want to change your mind. Okay, I require more amount of exposure in case you encounter any kind of bony defect. and you want more kind of exposure at that time, you can easily modify. So in the posterior areas, you can start with your basic envelope flap and then modify into something more extensive. And since there is no vertical incision, your blood supply is also comparatively less hampered, because all your flap success also depends upon that you're not severing the blood supply much. The tissue should not go into hypoxia. And if there is no vertical incision, there will be less suturing, your less scar formation, and ultimately your better tissue adaptation. And the drawback also is that it gives a tension while you close. So in cases of guided bone regeneration, where your entire procedure depends upon how well the flap holds the graft and how much there is, the flap advancement is much less more. It should be very tension free, absolutely very passive. So in cases of envelope flap, you might not get that kind of passivity of flap that we look for if you are looking for any augmentative procedures. Now coming to another flap, which is usually can be done while you're having your second stage surgery. So it is a modified version of your envelope flap. It is a Placci flap. So why we do this? Because you have opened your implant um, after 2 months or 3 months, whenever it is osseointegrated. Now you want to go for your restorative procedure. It should have your supporting papilla. Any kind of procedure in which basically any kind of periodontal plastic procedures, the most difficult thing is to regenerate the papilla more than anything else. And when you don't have your proper interdental papilla, you will have black triangles. There will be interdental spaces, and no matter how much good you place your implant and how well your prosthesis you have given it, those interdental spaces will get some amount of foot lodgement, and your patient will definitely complain about it more than how he or she may chew. There will be constant complaint of some amount of food getting stuck in those interdental papilla spaces. So Placci flap is basically you do an envelope flap, how we have discussed. There's some amount of intercircular incision, your midcrestal incision there. This is your healing abutment you have placed. Now all you have to do is give a semilunar incision. Just a simple basic cut. And this will be movable. So all you have to do is just adapt on this side of your adjacent tooth and the rest on the other side. Now, if the flap is this much, very small, to decide on which side to rotate, you have to judge what kind of papilla deficient or what area is more important. Here, in this region, as compared to the molar, the interdental papilla height was more deficient. So we try to rotate the flap on this side. And once you rotate it, you just have to suture it. And your interdental papilla will be created. Now, coming to the next flap, that is your papilla sparing flap. Again, the papilla is to be preserved, is to be look out every time whether the height is adequate, inadequate, or what kind of the tissue texture of that papilla is. Because once the papilla is gone in any of your incisions or any of your implant placement procedures, it is almost next to impossible to regenerate it. It is very technique sensitive, and again, it will require you more amount of grafting. So basically, why to do things when you can simply avoid it? And all you have to be is mindful of your incision. Again, the best thing to do in anterior aesthetic region is to do this papilla sparing flap. All you have to do is just take the incision 1 mm to 1.5 mm from your adjacent teeth. So your interdental, interproximal papilla, that is preserved. Your incision line will run 1 to 1.5 mm adjacent to the tooth on both the sides. And based on whether you want to incorporate or push your tissue buccally, you can decide your mid-crestal incision, whether you want to place it more palatally or more buccally. You require to give vertical releasing incision, sometimes up till the mucogingival junction as well, and sometimes uh, away from it. Now, to judge whether you want to give it till mucogingival junction or be a short of it, all that is being dictated by how much access you want. Whether any kind of structures that are coming over here, whether any kind of bony defect is there. The more reflection you want, the more you have to go towards the mucogingival junction. Again, release in case there was this ridge, slight modification, slight ridge defect was there. So you put a graft and close it. Now, what will you do if you have frenum? Will you do a phrenectomy and then you will reflect the flap, or will you just place the implant based on what we have done previously on the very previous slide? You will reflect your flap like that. So the judgment of whether to incorporate your frenum in the incision lines or not, it again depends upon how much the tension pull of frenum is there. See, if your frenum is does not have any tension pull, that is okay. But if your frenum is coming in the center, now if we based on the previous principle that I've told, around approximately 1 to 1.5 mm distance should be there. So if the frenum is coming in the way, I would suggest reflect it. You need not do a phrenectomy. See, any kind of pull will cause recession. And most of the time, frenum does not have orbicularis oris insertion that much. So take a incision and reflect. Reflect your frenum as well till your mucogingival junction, where till the time you're satisfied, okay, there is passivity. There is no amount of pull is there. This is the attachment of the frenum deflected. It will not give you any kind of you know there won't be any kind of distortion of the muscular fibers or anything. We are just simply reflecting it. And coming to what the evidence have suggested in retrospective studies, your incision technique do affect on your gingival papilla height. So whether you're doing a Placci Flap or whether you are just doing a papilla sparing incision, the thought of preserving the papilla will definitely benefit you, and that is there in the evidence. It is undebatable. Now coming to the advantages, since your papilla is intact, either you have included in your flap or you have excluded, there will be no disruption of papilla. No disruption, better aesthetics. Your vasculature is unhampered. Again, better healing, faster healing, and better aesthetics. Now, coming to disadvantages, there will be a limited access. If you are trying to preserve the papilla, and if you're see if the space that we have is approximately 4 to 5 mm, so your 3 mm of space, we are not just opening the tissue, it is just the remaining amount of uh, space, that in that space we have to manage your implant placement or any kind of grafting that you require. So this is something which is a bit technique sensitive, and you might require a lot of patience and additional skills to, master it. Now, if we are talking about aesthetic zone, then we also have to think about whether there will be uh, the thickness that we require of the tissue, whether that can be achieved during your implant placement only, or you would require another augmentative procedures. So there's a modified palatal roll technique can be used during when you're planning for submerged implant placements, or can be used at your second stage surgery. It is up to you. If you're doing it while placement, better. If not, then during your second stage surgery. So the basis of this palatal roll technique is we are not taking a graft from your palate, but we are taking a graft in a way at the site of your implant placement. We require this tissue, and that we have to augment on the labial side. So it starts with a full thickness incision, and here there is a partial thickness incision. The reflection will go full and partial. And once you have the you have reflected it full mucoperiosteal flap on the labial side, and here you have reflected your full mucoperiosteal flap, and here you have done a partial thickness, and then the flap has been split. So all you have to do is just roll it inside here, tuck it. Again, this has to be passive. And after elevation, just suture it. So basically, it is again the thing that you have to think even while doing a mid-crestal incision is how much amount of tissue I want to push. The basis of all kind of flap almost remains the same. So once you suture it, let it heal. If you're doing during your second stage surgery, it might require more time, but during your implant placement, when you're doing a submerged implant placement, again, by the time the need arises to do a second stage or your prosthesis restorative phase, you will have a very thick gingival tissue on the labial aspect, so that will give comparatively better aesthetics. This is your first incision line, that is your intracircular, your mid-crested, again intracircular. And this is your second incision line, where you will decide how much amount of tissue you want to tuck inside on your labial aspect. So your second incision line varies based on how much thickness you want and how much amount of tissue surface that can be possibly tucked inside your labial aspect. First, you reflect a full thickness and then just keep your blade parallel and try to sever the thin epithelium. Take your adson forceps, just hold the tissue and just put your blade parallel and try to just take out your, holding it very stably, just try to move parallel. And once you have that, just roll it on your labial side. Again, it has to be very passively rolled. No amount of tension should be there. And when you're suturing, no amount of dead space should be there. Once you're done adapting, just take a gauze and just compress it. So your tissue to tissue, your connective tissue to connective tissue that we have harvested, there will be they will act as a bioadhesive structure. And then just suture it. Again, you can see there's this shadow. That means there's thin tissue. There is frenum. So if there is frenum, there's going to be recession. The depth is also quite less, the vestibular depth. So what we'll do, again the same thing. Can be done for single implants, can be done for multiple implants. Again, we have reflected till the frenum. Frenum is passively falling. This is the kind of results that we get. Now coming to the next one, that is your triangular flap. It is very similar to your envelope flap, but it does have a vertical releasing incision. So again, the incision goes intracircular, mid-crestal, intracircular, and one vertical releasing incision. Now, when you're doing any sort of vertical releasing incision, the thing that you have to make sure is your vertical releasing line should not be on mid of any tooth. Either you include the papilla or you completely exclude the papilla. It should not be on mid papilla or um, any kind of root prominences, because it will be very difficult for you to suture on the root prominences. If there is a prominence, there will be some amount of tension and there are chances of sutures, it might get open and it will give a certain amount of recession. So mid-crestal, intracircular, mid-crestal, intracircular, and the releasing incision is on this side. Again, the releasing incision, if you see, it is not straight. It is not, it is excluding the papilla. And again, it is not going in a very straight line, even though it is excluding the papilla. Your base of your flap has to be always broader than your main area of where you're trying to place implants. Your broader base will judge how much amount of blood supply your flap still has. So your base has to be always broader than your. So this is the releasing incision that I was talking about. Again, broader base. And this has to be narrower compared to your base. Trapezoidal flap is again the same thing, but instead of single releasing incision, it has multiple releasing incision, that is two incision. The principle remains the same. The base will be broader. The incision line, it won't be at the center of the tooth. There will be inclusion completely or exclusion of papilla. Now, if you see this flap and compare it with this flap, the amount of exposure that we are getting is much more in the trapezoidal flap. So again, you can start with your envelope flap, your mid-crestal and intracircular incision. Think of the axis that you have. If not, then give a vertical releasing incision. If that does not suffice, give another vertical releasing incision. And if you can see, we can see a defect over here. So this flap is very good for when you want to do any procedures that require your bone augmentation. You can have your complete debridement done. The releasing incision will make the flap very tension free. Again, reflect reflection till how at least there should be 2 to 3 of reflection from the defect should be present, so that even if you augment it, the closure will be very nice. There will be some amount of flap elongation. Release it till your mucogingival junction. As I said, it is the best flap if you want maximum visibility. And when you're trying to, since you have reflected till your mucogingival junction, your closure will also be very tension free. And sometimes while doing your implant placement, you may come across, okay, the adjacent tissue has some amount of recession, or the adjacent tooth also requires some amount of augmentative procedures. So all that can be done in a single go. You don't have to plan it separately. Now coming to the disadvantage, this will definitely cause bone loss and recession. Though the bone loss and recession will be uh, very small, it will be even less than 1 But when you are reflecting the periosteum and when there is disruption of blood supply, some amount of bone loss will occur. And since the reflection is still your mucogingival junction, there is additional incision line. The amount of edema that you might get is comparatively much more than other flaps that we have discussed. And there's lot of chances that your flap might necrose from the edges if you do this, but there's a way to go about it. You can keep the area moist. Have your saline irrigation. Don't let the tissue dry out. The more you will keep it moist, the better the blood supply. It will retake the blood supply. You don't want tissue hypoxia. And if you are reflecting your flap or if you're doing any procedures and you can see, okay, the edges of your tissues are turning bit white, turning bit pale, then you need a constant irrigation. Again, your normal saline works. Now we have talked about uh, augmentative procedures. Now, what if we require reductive procedures? See, in case of full mouth implants, you can go flapless. You have your dentures. You can go flapless. You have your stent again. But sometimes you do require bony reduction. There's uh, the bite has collapsed. The lower anterior region has supra-erupted teeth. So your teeth has erupted. Your bone has moved a bit up. At that time, even though flapless will be much easier, but to give a perfect aesthetic and your balanced occlusal results, you would require reductive procedures. So this is done with the help of a stent. But for reductive procedure, you require to open a flap. So not every case can be done flapless. You do require to have knowledge of how to raise a flap. This is after reduction. This case was done with help of Quickdent implants. Now I have talked so much about tension-free closure, and your flap should have passivity. You should elongate the flap so that your entire site is covered, your bone margins are covered. But how to do it? So there's a thing called as your periostal releasing incision. This periostal releasing incision, all you have to do is keep your blade parallel and very, very slight movements. You don't need to go very deep. Just try to sever the tissue and reflect from where your incision line is. There is clean bone you can see. Your flap has elongated as compared to previously. How much tension it had. Like at the start, it had quite much of a tension. And if you're doing any procedures, it will be very difficult even after implant placement to cover that. If you're doing a submerged implant placement, or even if there's no uh, augmentative procedure, but the closure is important. You might not even do it completely as in tibia mucogingival junction, but try to adapt the flap and see whether it is covering your bone, whether it is passively covering your bone. Your sutures are there to just hold the flap. It is not to, pull the flap. Look at the passivity. Keep on checking. If you require it, then do more of your periostal releasing incisions. Now we have already talked about your flap reflection and your incision. Now let us talk about how you will close it. So in implants, even though there are lot of suturing techniques, all you require is just three techniques: your basic interrupted suture and your mattress sutures and your membrane stabilizing suture. These three sutures, any area, you can maneuver that. Your basic interrupted suture is, again, take a bite from buccal, go to the other side, take a bite, entire knot. Again, two loops forward, one loop backward. Your surgeon's knot. Very basic in any kind of, and this is something which everybody does it routinely. It does not require much of a skill. But when it comes to your augmentative procedures along with your flap, in your flap while placing your implants, you would require a mattress suture. So a horizontal mattress suture, when there is slight amount of tension is there in the flap, but you still want it to be adapted very passively. In that cases, take take a bite from your buccal, move adjacent to that, take a bite again. First your buccal, then your lingual, take a bite again on the other side. And your knot should always be on the buccal side. And when you're pulling, you don't have to pull it so hard that you can see there's tissue necrosis or any kind of tightness that you will give that will ultimately lead to your wound might open. Your horizontal mattress suture has to be started quite low. Again, insert your needle, take it out, go to the other side, then insert from here and tie a knot on this side. This is usually done quite at the ridge level, quite lower from the ridge level. And once it is adapted without any tension, then you can give your simple interrupted suture on top of this. Something like this. This is a continuous interrupted, but your regular interrupted suture might work. This is your horizontal mattress. Your vertical mattress is same, but only thing is it is more it we imagine being rotated it vertically instead of being horizontal. So take a bite from buckle. You have to start approximately 5 to 7 mm, and sometimes you don't even have that kind of ridge height. So you cannot give it in those cases. In those cases, you have to rely on your horizontal mattress. But when you have nice ridge height and you want to do regenerative procedures, at that time, the best suture to be given is your vertical mattress suture, specifically when you're doing GBR procedures, because at that time you do require somewhat everted margins. Your adaptation should be your connective tissue to connective tissue. It cannot be connective tissue to epithelium. If there is connective tissue to epithelium, your flap will not, the wound healing will not be that good. The epithelialization will not be that good. So your vertical mattress is take a bite, go inside to the flap, then take a bite again, move it to your other lingual side, then repeat the same and tie the knot on the your labial or buccal side. Now imagine if you have raised a flap, you have raised your periosteum. This is somewhat a partial thickness flap, and you want to do an augmentative procedure. You have placed your implant, but it requires some amount of bone graft or membrane is there. So the basic principles of GBR is it should be as passive as possible. Your wound closure should be there, and there should be space creation. You don't want your membrane to move out once you're suturing the flap. Then what is see, if there is a defect, if you want your bone to form, what amount of cells, what kind of cells that will come that will decide whether there will be bone formed or not. If you're putting bone graft over here, you want your bone cells to reach there first instead of your epithelial cells. So you put a membrane. But again, if your membrane moves, the epithelial cells will come to the defect and there will be no bone regeneration. It will be simply the defect will be filled with your granulation tissue, your soft tissue. The soft tissue, it will just adapt it over there, but there will be no bone formation. So what you require is a membrane stabilizing suture. Your membrane stabilizing suture can be your vertical mattress or your horizontal mattress. All you have to do is incorporate the membrane and give a horizontal mattress similar to what was discussed and just try to adapt it and suture it on the lingual side first and then close the flap and suture it again. You want your membrane to be stable and completely covering your uh, the defect area. If you see this, there is bone graft, there is a membrane, and this is the periosteum. So we have taken the bite from your lingual side. Then again, we have adapted it. If you can see your this side of the membrane is covering to the lingual side as well. So this complete side, we have incorporated the suture very superficially into the periosteum. It is not going through and through your entire mucoperiosteal region. It is just engaging the periosteum, very superficial. And then you cover it. So even when you close the flap, the membrane, it stays stable. Again, if one mattress suture is not enough, it is okay to divide it and then cover it. Cover, be as passive as possible, and your membrane has to be as stable as possible. Nowadays, nobody, I don't think so. A lot of times we don't use non-resorbable membrane. Mostly what we move forward is the collagen membrane. It is bioadhesive. So even if it is not incorporating the membrane, it has to be stable. Move your sutures. You don't need to pierce your suture through the membrane. You just have to create a barrier so your membrane stays stable. Now coming to how will you select your flap? All you have to think is my bone volume where I have to place implant is sufficient. If it is, then go for flapless approach. And the keratinized tissue has also, it has to be adequate. But again, if it is not, then you can even manage in your second stage surgeries with your CTG grafts or your FGG grafts. But if not, see, soft tissue always follows the bone. If there is no bone, there will be no soft tissue. So it has to go in a very reverse manner. You have to think of your bone first and rest follows. If no, then you have to open your flap. There is no other way. Your flapless won't work. Think of the number of implants to be placed. If it is single or if it is multiple. Single implant, envelope flap is enough. Minimal trauma. Just a tiny midcrestal and two intercircular incision done. If there is multiple implants, then you have to give releasing incisions. Have your triangle or trapezoidal flap for access. If it is in aesthetic zone, then there has to be papilla preservation flap or roll flap to be done. If no, then based on your access needs, you can just go with any kind of flap. Preserve the papilla, but again, you don't have to think much about the roll technique or anything. If guided bone regeneration is required, then it has to be a full thickness flap with periosteal releasing incision. If not, then your standard flap, based on how much access you require, you can make a decision at that time. So to summarize and to give you a takeaway from my session, if possible, keep your periosteum intact. It should not be removed unnecessarily. Periosteum is very, very helpful uh, when you want proper wound healing, when you don't want the blood supply to your bone to be severe. See, when we are placing an implant, we are continuously irrigating it, so you don't want your bone to be heated. But then you have to think about the soft tissue also. That you know that also helps your bone healing. Your periosteum actually helps your bone to heal. So even though there is copious irrigation and everything, you have to think about how much periosteum you're reflecting, whether it is traumatic reflection or not. If vertical incisions to be given, it should be given in an oblique way so that you have a broader base of the flap. And whenever you're reflecting, you can have your have the anatomy in mind before reflecting. If you're reflecting in the lower region, there might be mental nerve. You are thinking, okay, I want a passive flap, and you're going on reflecting, but you might damage a nerve. So anatomy has to be always taken into mind before thinking liberal how liberal you want your mucogingival release to be. In sublingual region, you don't want any hematoma. Your tongue space that might even alter your respiratory passage. The edges of the flap should be clean. See, whenever you're giving an incision, think of the adaptation. The co-adaptation should be connective tissue to connective tissue. So if you encounter any granulation tissue, try to remove it. Try to curate it. Thin it with the scissors. And then your adaptation will be your connective tissue to connective tissue. Your flap should have adequate blood supply all the time. That is non-negotiable. And you have to also think while you're suturing, while you're doing any kind of flap elongation, is your vestibular depth is also being hampered. See, vestibular depth plays a lot of function. As simple as if a patient wants to brush his teeth, but lot of time if the vestibular depth is less, that toothbrush might hurt. So if you're doing any horizontal mattress which is very closer to your vestibular region, think whether you are not just shrinking the vestibular depth. You have to think on other sides as well. And also, if your if the blood supply is good, your flap closure is good. Again, all this will ultimately help your patient factors as well as your outcome of your implants. The suturing has to be absolutely under no tension. And if you're giving in case of where there is inadequate keratinized tissue, crestal incision should be given more palatally, more lingually, and avoid tissue trauma. Asepsis and tissue trauma, that is actually in your hands, that can be taken care of. So to conclude, uh, thank you Quickdent Implants and thank you Dentist Channel Online for hosting this session.
Thank you so much, Dr. Tejashvi, for such a wonderful presentation. So now it's Q&A round. So let me take questions one by one. So yes, first question is from Vijas Deep. Incisive papilla, if it comes in the way of an incision, should we reflect it or spare it?
See, if the papilla is coming on the way of incision, again, judge whether it is an aesthetic zone or not.
Mm.
In case of non-aesthetic zone, and in case where you don't have the interpapilla height itself, there is no papilla to preserve it. At that time, it is okay. But if you have papilla, if you can see it, if the height is adequate, try sparing the papilla. Don't give mid-papillary incision. Either you completely include the papilla in your flap or you completely avoid it. Don't just dissect in between.
The next question is from Tanisha Rajput. Can you explain about papilla preservation flap incision like incision A or B?
See, you are giving a intracircular incision and a mid-crestal incision. So now there are two sides. Your intracircular is there and your mid-crestal is there. And your incision B is this one. That is inside the flap. It will be your connective tissue that you're harvesting from the very same side, from the palatal side that you have to move towards your labial side. So your incision will be this parallel, keeping the blade parallel and then just taking out the tissue. Again, there should be, the connection should not be. See, this is basically your mid crestal is not completely, hitting the bone. The intracircular is, but your mid crestal is again bit superficial when you want to raise a partial thickness flap. I hope it is understood now.
Okay. So the next one is from Shruti Joymon. What are the chances of black triangle formation in palatal roll technique?
See, black triangle, if we are doing palatal roll technique, if I just show you that slide. See, while you're doing a palatal roll technique, all you have to think of just whether you want to give patient temporaries or not. If any kind of ridge augmentation procedures that we come across, usually whenever we give any kind of roll flap in that, we adapt the temporaries at that time. So you get a nice emergence profile. So your tissue healing is in such a way that you will get your papilla around because there's some structure that is present, so your gingiva adapts over there. So the black triangle formation will be comparatively lesser if you are giving your temporaries. Again, even if you have submerged your implant, uh, you're thinking of, okay, I'll do a delayed implant placement. So again, during your second stage, do your palatal roll technique and then give temporaries. At that time, it is okay to load for your temporaries. And after some time, after a month or so, give your final prosthesis.
Okay, the next one is from Ashish Sukhija. I'm struggling to close the wound in immediate implant loading in upper molar. How to give flap lengthening incision? Kindly elaborate it.
Can you repeat? Is it immediate implant placement
Yes.
in an extraction socket?
In upper molar or maybe in the extraction socket, maybe.
See, in cases of extraction socket, the best way, you have to see whether there is any kind of bony dehiscence is present or not. You can check in your CBCT. If there is any bony dehiscence and if you're reflecting your flap at that time and you're doing an immediate implant placement, then it might not work. At that time, all you can do is once you have placed the implant, put a collagen plug and give a figure of it or a crisscross suture so that your collagen plug becomes stabilizes. And then it will ultimately close with secondary intention. But once your collagen plug is there, it swells up, it covers the wound, your clot is also stabilized.
Okay, the another question is again from Ashish. Ma'am, sometime in maxilla gingiva is very thin in texture. In that time, how can we for flap elongation?
See, if your gingiva is thick or thin,
Thin, thin in
thin,
texture.
okay. thin in texture. Again, if you don't require any augmentative procedure, your flap elongation is okay. All you have to do is release your till your mucogingival junction. You have to constantly check whether it is getting adapted or not. If not, then you don't place the blade parallel and give very superficial dissecting, dissecting your fibers. Just release it. Or even if you're not comfortable, you're scared that okay, I might just sever any kind of blood vessels, then just take a blunt periosteal elevator and just try to release it. Your flap elongation has nothing to do with your thickness or thinness. Your partial thickness flap, at that time, when you're raising a partial thickness flap, at that time you have to think of your biotype, whether it is thick or thin. If it is in thin region, then the flap might tear.
Yeah. The next question is PRP or GTR membrane mandatory in case of corticobasal implant cases?
Sorry.
He means to ask that in case of corticobasal implant cases,
Hmm.
PRP or GTR membrane, is it necessary? Is it mandatory?
You judge it. That depends upon your placement. If for me, I can say according to what I prefer, if I can see some amount of exposed threads, I would do a GPR.
Okay. Next one is from Brajesh. Which suture material is used? Monofilament or multifilament, and which size? 30 or 40?
See, there's no question that you want to use multifilament. Your multifilament will take a lot of plaque. And if there's a lot of bacteria around your wound, you can think of how will your wound heal faster. So it has to be monofilament. And see, when your suture should hold the flap. So if there is a very extensive region where I don't require in non-aesthetic zone where I don't require GBR, GTR, then I go for 30 silk suture or your any kind of absorbable suture. Very small region, that is okay. But in cases where you're planning any augmentative procedure, you will require for soft tissues a finer suture, 4050. And it has to be monofilament and it has to be absorbable.
Okay. Next question is from Dental Bud Polyclinic. Any bone char material put outer side of implant before suturing to support the implant?
Again, that becomes your GBR procedure only. So if you want to, you can, if there are thread exposed, or if you want to place the implant and augment at the same time, but you have to give micro perforations on your labial side so that your grafts also adapts.
Okay, so this was the end of the Q&A round. So yes, thank you so much for joining with us. And I think the takeaway note can be that you can use these techniques, these steps, this process to elevate your practice, ensuring a comprehensive and efficient and predictable treatment that prioritize patient satisfaction and clinical excellence. So these were my words. Okay. So thank you once again, everyone, for joining with us, and thank you so much, Dr.
Thank you.
Tejashvi, for
Thank you
sharing
so
such
much.
knowledge. Thank you. Thank you, everyone. Good night.
Good night.